This is Justine Sparrgrove recording Chapter 16 on depressive disorders. Symptoms of depression have been described almost as far back as there's evidence of written documentation. An occasional feeling of sadness or downheartedness is common among healthy people and considered to be normal response to everyday disappointments in life. Pathological depression occurs when adaptation is ineffective and the symptoms are significant enough to impair functioning. Mood and depression. Mood is a pervasive and sustained mood that may have a major influence on a person's perception of the world. Examples of mood include depression, joy, elation, anger, and anxiety. Affect is described as the external, observable emotion reaction associated with an experience. Depression is an alteration in mood that is expressed by feelings of sadness, despair, pessimism. There's a loss of interest in usual activities, and somatic symptoms may be evident. Changes in appetite, sleep patterns, and cognition are common. Historical perspectives of depression. Many ancient cultures have believed in the supernatural or divine origin of mood disorders, but a non-divine point of view regarding depression was held by the Greek medical community from the 5th century BC through the 3rd century AD. This represented the thinking of Hippocrates, Celsus, and Galen, among others. They strongly rejected the idea of divine origin and considered the brain as the seat of all emotional states. During Renaissance, several new theories evolved, and depression became viewed by some as being the result of obstruction of vital air circulation, excessive brooding, or helpless situations beyond the client's control. Contemporary thinking has been shaped a great deal by the works of Sigmund Freud, Emil Kraepelin, and Adolf Meyer. These various perspectives support the notion of multiple causations and development of mood disorders. Epidemiologic statistics of depression. Major depressive disorder, or MDD, is one of the leading causes of disability in the United States. The lifetime prevalence of depression is about 17%, which makes it the most prevalent psychotic disorder. Research indicates that the incidence of depressive disorder is higher in women than it is by men by almost 2 to 1. The gender difference is less pronounced between the ages of 44 and 65, but after the age of 65, women are again more likely to be depressed than men. The construction of gender stereotypes or gender socialization promotes typical female characteristics such as helplessness, passivity, and emotionality, which are associated with depression. In contrast, some studies have suggested that masculine characteristics are associated with higher self-esteem and less depression. Results of some studies have indicated an adverse relationship between social class and report of depressive symptoms. However, there is yet to be a definitive causal structure in the socioeconomic status, mental illness relationship. Studies have shown no consistent relationship between race and affective disorder. One problem encountering in reviewing racial comparisons has to do with the socioeconomic class of the race being investigated. Sample populations of non-white clients are often predominantly lower socioeconomic class populations that are being compared with white populations from middle and upper social classes. A number of studies have suggested that marriage has a positive effect on psychological well-being of an individual. Other studies have suggested that marital status alone is not a valid indicator of risk for depression. Some of those studies have identified that age is an important variable in risk for depression among married and single individuals. Studies exploring whether seasonality is a cause of depression have yielded varying results. Authors of one large study report that prevalence rates of depression with seasonal patterns have varied from 1% to 12%, but in their study, 5,549 patients from primary care settings, there was no evidence of seasonal pattern for majority of depressive disorder. Another study found that a small but significant peak in depression symptoms occurred in winter months, but over 20 years of following those clients, the winter seasonal pattern was not stable. Characteristics of major depressive disorders. Major depressive disorders, or MDD, is characterized by depressed mood or loss of interest or pleasure in usual activities. Evidence will show impaired social and occupational functioning that has existed for at least 2 weeks, no history of manic behavior, and symptoms that cannot be attributed to those of substance or a general medical condition. The diagnosis will identify the degree of severity of the symptoms, mild, moderate, or severe, and whether there's evidence of psychotic, catatonic, or melancholic, saddening, or depressed features. Dysthymia. Characteristics of persistent depressive disorder, or dysthymia, are similar and perhaps milder than MDD. There's no evidence of psychotic symptoms. The essential feature is a chronically depressed mood, or possibly an irritable mood in children or adolescents, for most of the day, more days than not, for at least 2 years, 1 year for children and adolescents. The diagnosis is identified as early onset, occurring before age 21 years, or late onset, occurring at age 21 years or older. Premenstrual dysphoric disorder. The essential features of premenstrual dysphoric disorder include markedly depressed mood, excessive anxiety, mood swings, and decreased interest in activities during the week prior to menses, improving shortly after the onset of menstruation, and becoming minimal or absent in the week of post-menses. Substance-induced depressive disorder. The depressed mood is associated with intoxication or withdrawal from substances such as alcohol, amphetamines, cocaine, hallucinogens, opioids, phenylclidine-like substances, sedatives, hypnotics, or anxiolytics. The symptoms meet the full criteria for relevant depressive disorder. A number of medications have also been known to evoke mood symptoms, including anesthetic, analgesics, anticholinergics, anticonvulsants, antihypertensives, anti-Parkinsonian agents, anti-ulcer agents, cardiac medications, oral contraceptives, psychotropic medications, muscle relaxants, steroids, and sulfonamides. Characteristics of depressive disorder associated with another medical condition. This disorder is characterized by symptoms associated with major depressive episode that are the direct consequences of another medical condition. The depression causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. The cause of depression is unclear, and no single theory or hypothesis offers a clear-cut explanation for the disease. Evidence continues to mount in support of multiple causations. Let's look at the biological theories of the causes of depression. A genetic link has been suggested in numerous studies of depression, but a definitive mode of genetic transmission has yet to be proven. Twin studies suggest a strong genetic factor in the etiology of affective illness, including depressive disorders. Family studies have shown that major depression is more common among first-degree biological relatives of people with the disorder than among the general population. Further support for hereditary, there we go, as an etiological influence in depression comes from studies of the adopted offspring of affectively ill biological parents. Depressive illness may be related to a deficiency of the neurotransmitters norepinephrine, serotonin, and dopamine at functionally important receptor sites in the brain. More recently, this hypothesis has been expanded to include another neurotransmitter, acetylcholine. Because cholinergic agents do have profound effects on mood, electroencephalograms, sleep, and neuroendocrine function, it has been suggested that the problem in depression and mania may be an imbalance between the biogenic amines and acetylcholine. Neuroendocrine disturbances may play a role in the pathogenesis or persistence of depressive illness. In clients who are depressed, the normal system of hormonal inhibition fails, resulting in a hypersecretion of cortisol. Thyrotropin-releasing factor, or TRF, from the hypothalamus stimulates the release of thyroid-stimulating hormone, or TSH, from the anterior pituitary gland. Diminished TSH response to the administered TRF is observed in approximately 25% of depressed persons and appears to be associated with the increased risk for relapse despite treatment of antidepressants. A number of drugs, either alone or in combination with medications, can produce a depressive symptom or syndrome. Most common among these drugs are those that are of direct effect on the central nervous system. An individual who has suffered a cardiovascular accident, brain tumors, particularly in the area of the temporal lobe, Alzheimer's disease, Parkinson's disease, and Huntington's disease, or multiple sclerosis may display symptoms of depression. Excessive levels of sodium bicarbonate or calcium can produce symptoms of depression, as can deficits in magnesium and sodium. Potassium was also implicated in the syndrome of depression. Depression is associated with the dysfunction of the adrenal cortex and is commonly observed in both Addison's disease and Cushing's syndrome. Other endocrine conditions that may result in symptoms of depression include hypoparathyroidism, hyperparathyroidism, hypothyroidism, and hyperthyroidism. An imbalance of the hormones estrogen and progesterone has been implicated in the predisposition to premenstrual dysphoric disorder, or PMDD. Although the exact etiology is unknown. Deficiencies in proteins, carbohydrates, and vitamin B1, thiamine, vitamin B2, riboflavin, vitamin B6, peroxidine, B9, folate, B12, iron, zinc, calcium, chromium, iodine, lithium, selenium, potassium, and omega-3 fatty acids have all been associated with producing symptoms of depression. Other conditions that have been associated with secondary depression include collagen disorders such as systemic lupus erythematosus, SLE, and polyarthritis nodosa, cardiovascular disease such as cardiomyopathy, congestive heart failure, and myocardial infarction, infections such as encephalitis, hepatitis, mononucleosis, pneumonia, and syphilis, and metabolic disorders such as diabetes mellitus and porphyria. All right, let's look at the psychosocial theories of the causes of depression. Freud suggested that melancholia, a mental condition characterized by extreme depression, bodily complaints, and often hallucinations and delusions, occurs after the loss of a loved object, either actually by death or emotionally by rejection, or the loss of some other abstraction of value to the individual. Freud indicated that melancholia, the depressed patient, rage is internally directed because of identification with a lost object. Freud believed that the individual predisposed to melancholia experience uncertainty in love relationships. As a result of Seligman's experience with dogs, he theorized that learned helplessness predisposes individuals to depression. By imposing a feeling of lack of control over their life situation, he believed they become depressed because they feel helpless. They have learned that whatever they do is futile or pointless. The theory of object loss suggests that depressive individuals occurs as a result of having been abandoned by or otherwise separated from a significant other during the first 6 months of life. This absence of attachment, which may either be physical or emotional, leads to feelings of helplessness and despair that contribute to lifelong patterns of depression in response to loss. Beck and colleagues proposed a theory suggested that the primary disturbance in depression is cognitive rather than affective. The underlying cause of depression is cognitive distortions that result in negative, defeated attitudes. These cognitive distortions arise out of a defect in cognitive development, and the individual feels inadequate, worthless, and rejected by others. Outlook for the future is one of pessimism and hopelessness. Depression in childhood. It is not uncommon for the symptoms of depression to be manifested differently in childhood. These symptoms change with age. Up to age 3, signs may include feeding problems, tantrums, lack of playfulness and emotional expressiveness, failure to thrive, or delays in speech and gross motor development. From ages 3 to 5, common symptoms may include accident proneness, phobias, aggressiveness, and excessive self-reproach for minor infractions. The incidence among preschool children is estimated to be between 0.3 to 0.9%. For ages 6 to 8, there may be a vague physical complaint and aggressive behavior. They may cling to parents and avoid new people and challenges. They may lag behind their classmates in social skills and academic competence. From ages 9 to 12, common symptoms include morbid thoughts and excessive worrying. They may reason that they are depressed because they have disappointed their parents in some way. There may be a lack of interest in playing with friends. The incidence of depression among school-age children is estimated to be around 2 to 3%. Other symptoms of childhood depression may include hyperactivity, delinquency, school problems, psychosomatic complaints, sleeping and eating disturbances, social isolation, delusional thinking, and suicidal thoughts or actions. The focus of therapy with depressed children is to alleviate the child's symptoms and strengthen the child's coping and adaptive skills with the hope of possibly preventing future psychological problems. Parental and family therapy are commonly used to help the younger depressed child. Recovery is facilitated by emotional support and guidance to family members. Developmental implications of depression in adolescence. Depression may be even harder to recognize in an adolescent than in younger children. Common symptoms of depression in adolescent are inappropriately expressed anger, aggressiveness, running away, delinquency, social withdrawal, sexual acting out, substance abuse, restlessness, and apathy. Loss of self-esteem, sleeping and eating disturbances, and psychosomatic complaints are also common. A visible manifestation of behavioral change that lasts for several weeks is the best clue for a mood disorder. Examples include the normal outgoing and extroverted adolescent who has become withdrawn and isolating themselves, the good student who previously received constantly high marks but is now failing at skipping classes, and the usually self-confident teenager who is now inappropriately irritable and defensive with others. Treatment of the depressed adolescent is often conducted on an outpatient basis. Hospitalization may be required in cases of severe depression or threat of imminent suicide when a family situation is such that treatment cannot be carried out in the home, when the physical condition precludes self-care of biological needs, or when the adolescent has indicated possible harm to self or others in the family. In addition to supportive psychosocial intervention, antidepressant therapy may be part of the treatment of adolescent mood disorders. Developmental implications of depression in the elderly. Depression is the most common psychiatric disorder of elderly, who make up 13.1% of the general population of the United States. Symptoms of depression in the elderly are not very different from those in younger adults. Depressive symptoms in older adults are often confused by their illnesses associated with the aging process. Symptoms of depression are often misdiagnosed as neurocognitive disorder. The most effective treatment of depression in elderly individuals is thought to be a combination of psychosocial and biological approaches. Antidepressant medications are administered with consideration for age-related physiological changes in absorption, distribution, elimination, and brain receptor sensitivity. Electroconvulsive therapy is an important alternative for treatment of major depression in the elderly, especially considering the problematic side effects of antidepressants in this population. Developmental implications of postpartum depression. Of women who give birth, approximately 50 to 85% experience the blues following delivery. The incidence of moderate depression is 10 to 20%. Severe or psychotic depression occurs rarely in about 1 or 2 out of 1,000 postpartum women. Symptoms of moderate postpartum depression have been described as depressed mood varying from day to day, with more bad days than good, tending to be worse toward the evening and associated with fatigue, irritability, loss of appetite, sleep disturbances, and loss of libido. These symptoms usually develop during the first few days following birth, but may occur later. Treatment of postpartum depression varies with the severity of the illness. Psychotic depression may be treated with antidepressant medication, along with supportive psychotherapy, group therapy, and possibly family therapy. Moderate depression may be relieved with supportive psychotherapy and continuing assistance with home management until the symptoms subside. Symptoms of depression can be described as alterations in 4 spheres of the human functioning: affective, behavioral, cognitive, and psychological or physiological. Alterations within these spheres differ according to the degree of severity of the symptomology. Symptoms of transient depression. Symptoms at this level of the continuum are not necessarily dysfunctional. Transient depression subsides quickly, and the individual is able to refocus on other goals and achievements. Affective is the blues. Behavior will be some crying. Cognitive, some difficulty getting mind off one's disappointment. And physiological is feeling tired and listless. Symptoms at the middle level of depression are like those associated with uncomplicated grieving. Affective would be anger and anxiety. Behavioral, tearful and regression. Cognitive, preoccupied with loss. And physiological, anorexia and insomnia. Symptoms of moderate depression. Dysthymia, also called persistent depressive disorder, is an example of moderate depression and represents a more problematic disturbance, which according to the DSM-5 is characterized by symptoms that are enduring for at least 2 years. Affective is helpless and powerless. Behavior, usually slowed physical movements, slumped posture, limited verbalization with concentration, and physiological, anorexia or overeating, sleep disturbances, and headaches. Severe depression, also called major depressive disorder, is characterized by an intensification of symptoms described for moderate depression. Affective shows feelings of total despair or worthlessness and a flat affect. Behavior, psychomotor retardation, curled up position, absence of communication. Cognitive, prevalent delusional thinking with delusions of persecution and somatic delusions, confusion, and suicidal thoughts. Physiological, a general slowdown of the entire body. Using information collected during your assessment, the nurse would complete a database from which selection of the appropriate nursing diagnosis would be determined. So, in your book in Table 16.1, it represents the list of clients' behaviors and the NANDA nursing diagnosis that corresponds to those behaviors, which all can be used in planning for care of the depressed client. So, the most common ones here, nursing diagnosis-wise, we risk for suicide related to depressed mood, feelings of worthlessness, anger, turned inward on self, and misinterpretations of reality. Another one, complicated grieving related to real or perceived loss, bereavement overload, low self-esteem related to learned helplessness, feeling of abandonment by significant others, and impaired cognition fostering negative view of self. And then powerlessness related to complicated grieving process or lifestyle of helplessness, and spiritual distress related to complicated grieving process over loss of valued object, evidenced by anger towards God, questioning meaning of own existence, inability to participate in usual religious practices. And then social isolation, impaired social interaction related to developmental regression, egocentric behaviors, fear of rejection, or failure of the interaction. Then disturbed thought processes related to withdrawal into self, underdeveloped ego, punitive superego, impaired cognition fostering negative perception of self or environment, imbalanced nutrition, less than body requirements, insomnia, self-care deficit, all related to depressed mood. All right, let's check your understanding. An individual experienced the death of a parent 2 years ago. This individual has not been able to work since the death, cannot look at any of the parent's belongings, and cries daily for hours at a time. Which nursing diagnosis most accurately describes this individual's problem? post-trauma syndrome related to parent's death, anxiety severe related to parent's death, coping ineffective related to parent's death, and grieving complicated related to parent's death. The correct answer here is D. The excessive reactions the individual continues to exhibit, such as daily crying, inability to return work, and an inability to look at parents' belongings after a 2-year period, are indicative of dysfunctional or complicated grieving. This individual's grieving response has arrested in the anger stage, is being turned inward on self, and is manifested by symptoms of depression. The following criteria may be used for measurements of outcome in the care of a depressed client. So the client has experienced no physical harm to self, discusses feelings with staff and family members, expresses hopefulness, sets realistic goals for self, and is no longer afraid to attempt new activities, is able to identify aspects of self-control over life situations. Those are all great outcomes. The more expresses personal satisfaction and support from spiritual practices, interacts willingly and appropriately with others, is able to maintain reality orientation, is able to concentrate, reason, solve problems, and make decisions, eats a well-balanced diet with snacks to prevent weight loss and maintain nutritional status, and sleeps 6 to 8 hours per night and reports feeling well rested, and bathes, washes, and combs hair, and dresses in clean clothes without assistance. Planning and implementation. Risk for suicide is defined as vulnerable to self-inflicted life-threatening injury. So goals for treating clients who are at risk for suicide should center on preventing the client from harming him or herself. Interventions include assessing frequently for the presence of suicidal ideation, maintaining close observation, and identifying sources that the client may use as support system. Complicated grieving is defined as a disorder that occurs after the death of a significant other or any other loss of significance to the individual, in which the experience of the distress accompanying bereavement fails to follow normal expectations and manifests in a functional impairment. Goals for treating clients who are experiencing complicated grieving should include identifying coping strategies, recognizing the client's own position in the grieving process, and progressing toward resolution. Interventions include determining the stage of grief in which a client is fixed, teaching the stages of grief, and encouraging the client to reach out for support to complete the process. Low self-esteem is defined as negative self-evaluating feelings about self or self-capabilities, whether long-standing or in response to a current situation. Self-care deficit is defined as impaired ability to perform or complete activities of daily living for self. Goals for treating clients with low self-esteem or self-care deficit should be to assist in ADLs, increase feelings of self-worth, and help the client satisfactorily accomplish ADLs independently. Interventions include promoting attendance in therapy groups, teach assertiveness techniques, and show the client how to perform activities with which he or she is having difficulties. Powerlessness is defined as the lived experience of lack of control over a situation, including a perception that one's actions do not significantly affect an outcome. Goals should be to include helping the client to participate in decision-making regarding their own care and to effectively problem-solve ways to take control of his or her life. Interventions could include encouraging the client to take as much responsibility as possible over their own care and setting realistic goals. So let's look at the client and family education for clients with depression. Topics for discussion with the client and family include the nature of the illness, including the symptoms of depression, management of the illness, including appropriate medication management, stress management techniques, and ways to increase self-esteem, and support services, including suicide hotline and support group information. Management of the illness, medication management, assertive techniques, stress management techniques, ways to increase self-esteem, and electroconvulsive therapy. Evaluation. In the final step of the nursing process, a reassessment is conducted to determine if the nursing actions have been successful in achieving the objectives of care. Evaluation of the nursing actions for the depressed client may be determined by asking the following questions. Has self-harm to the individual been avoided? Has suicidal ideation subsided? Does the individual know where to seek assistance outside the hospital when suicidal thoughts occur? Has the client discussed the recent loss with family and staff and family members? Different treatment possibilities for clients with depression. Therapy, whether in one-on-one environment or with a group, can be beneficial to a client suffering from depression. Personal psychotherapy focuses on the client's current interpersonal relations. Interpersonal psychotherapy with a depressed person is designed to encourage the client to continue working and participating in regular activities, helping the client resolve complicated grief reactions, and helping the client recover and enhance social functioning. Group therapy forms an important dimension of multimodal treatment for the depressed client. The element of peer support provides a great feeling of security, as troublesome or embarrassing issues are discussed and resolved. Therapy groups help members gain a sense of perspective on their condition and encourages them to link up with others who have common problems. Similar to group therapy, family therapy works with families of clients with mood disorders to resolve the symptoms and initiate or restore adaptive family functioning. In cognitive therapy, the individual is taught to control thought distortions that are considered to be a factor in the development and maintenance of mood disorders. The general goal in cognitive therapy are to obtain symptom relief as quickly as possible, to assist the client in identifying dysfunctional patterns of thinking and behaving, and to guide the client to evidence and logic that effectively test the validity of the dysfunctional thinking. Electroconvulsive therapy, or ECT, is the induction of grand mal seizures through the application of electrical current to the brain, and is effective with clients who are acutely suicidal and in the treatment of severe depression, particularly in those clients who are also experiencing psychotic symptoms and those with psychomotor retardation and neurovegetative changes. It should be considered for treatment only after a trial period with antidepressant medications has proven ineffective. Mechanisms of action are thought to increase levels of biogenic amines. Side effects, temporary memory loss and confusion, risks, mortality, permanent memory loss and brain damage, and medications, pre-treatment medication, muscle relaxant, and short-acting anesthetic. Transcranial magnetic stimulation, or TMS, is a procedure that is used to treat depression by stimulating the nerve cells in the brain. TMS involves the use of very short impulses of magnetic energy to stimulate nerve cells at localized areas in the cerebral cortex, similar to electrical activity observed with ECT. Unlike ECT, the electrical waves generated by TMS do not result in generalized seizure activity. It is non-invasive and considered generally safe. Vagal nerve stimulation, or VNS, was found to improve the client's mood. This treatment involves implanting an electronic device in the skin to stimulate the vagus nerve. The mechanism of action is not known, but preliminary studies have shown that many patients with chronic recurrent depression improved with the treatment of VNS. Trials are ongoing to determine its effectiveness. Deep brain stimulation, or DBS, like VNS, or vagal nerve stimulation, an electrode is implanted with the intent of stimulating brain function. However, this procedure, unlike vagal nerve stimulation, is deep implant and requires a craniotomy. Currently, deep brain stimulation is reserved for patients with severe incapacitating depression or observed compulsive disorder. Light therapy, or exposure to light, has also been shown to be an effective treatment for seasonal affective disorder. The light therapy is administered by 10,000 lux light box, which contains the white fluorescent light tubes covered with a plastic screen that blocks ultraviolet rays. The mechanism of action is believed to be related to retinal stimulation, which triggers a reduction of melatonin and an increase in serotonin in the brain. Psychopharmacology. Antidepressant medications is generally considered the first-line treatment for severe clinical depression, but is also used in other depressive disorders. These include tricyclic, tetracycline, and heterocycline antidepressants, MAOIs, SSRIs, SNRIs, SSRIs/SNRI combination drugs. A list of commonly used antidepressant medications is in your book on table 16.3 in the text. It's important to note that antidepressant medication can be lethal in overdose, so depressed, suicidal patients must be observed closely, and suicide risk assessment needs to be done frequently. Client and family education related to antidepressants. The client should continue to take the medication even if symptoms have not subsided, as the therapeutic effect may not be seen for as long as 4 weeks. The client should use caution when driving or operating dangerous machinery. Drowsiness and dizziness can occur. Do not discontinue use of the drug abruptly. To do so might actually produce withdrawal symptoms such as nausea, vertigo, insomnia, headache, malaise, nightmares, and return of symptoms for which the medication was prescribed. Report occurrence of any of the following symptoms to the physician immediately: sore throat, fever, malaise, yellow skin, unusual bleeding, easy bruising, persistent nausea and vomiting, severe headache, rapid heart rate, difficulty urinating, anorexia, weight loss, seizure activity, stiff or sore neck, and chest pain. Rise slowly from sitting or lying position to prevent a sudden drop in blood pressure. Take frequent sips of water, chew sugarless gum, or suck on hard candy if the dry mouth is a problem. Good oral care, including frequent brushing and flossing, is very important. All right, so avoid foods and medications high in tyramine when taking MAOIs. These include aged cheese, wine, beer, chocolate, colas, coffee, tea, sour cream, yogurt, smoked and processed meats, beef or chicken liver, canned figs, caviar, raisins, pickled herring, yeast products, broad beans, soy sauce, cold remedies, and diet pills. So pretty much, if you live in Wisconsin, it's not great to take MAOIs. Avoid smoking while receiving the tricyclic therapy. Smoking increases the metabolism of tricyclics, requiring an adjustment in dosage to achieve the therapeutic effect. Avoid drinking alcohol while taking antidepressant therapy. These drugs potentiate the effects of each other. And do not use other medications, including over-the-counter medications, without physician's approval. Many medications contain substances that could precipitate a life-threatening hypertensive crisis. Let's check your understanding. When teaching about a tricyclic group of antidepressant medications, which information should the nurse include? Strong or aged cheese should not be eaten while taking this group of medication. The full therapeutic potential of tricyclics may not be reached for 4 weeks. Long-term use may result in physical dependence, and tricyclics should not be given with anti-anxiety agents. The correct answer here is B. A client needs to be advised that it may take several weeks for tricyclic medications to reach a full therapeutic effect and for relief of symptoms to be noted. All right, a client has been diagnosed with major depression. The psychiatrist prescribes paroxetine or Paxil. Which of the following medication information should the nurse include in discharge teaching? Do not eat chocolate while taking the medication. The medication may cause priapism. The medication should not be discontinued abruptly, or the medication may cause photosensitivity. The correct answer here is C. Antidepressants such as paroxetine must be tapered and not stopped abruptly. All classifications of antidepressants have varying potentials to cause discontinuation syndromes. Abrupt withdrawal from SSRIs such as paroxetine may result in dizziness, lethargy, headache, and nausea. And that is it for this PowerPoint slide.